everyone, and welcome back to Mic Check
2.
Hey, this is Rachel, and we also have
Ajai
and Sean.
Yay! And today we have a very special episode for you all. We're going to be discussing breast cancer awareness. And we have two lovely ladies here today, so I'm going to allow them to introduce themselves.
Okay, hello everyone. My name is Dr. Prince. I'm a family nurse practitioner and director of clinic operations, and I've been with St. Hope since 2017. What drove me to St. Hope is my passion to care for the underserved population, as well as my desire to learn more specialized care with HIV patients.
And I'm Dr. Lynn Roberts. I have been with St. Hope since about 2016. I'm a family nurse practitioner. Most of my experience has been in ER and some in retail, and then I wanted to get back into primary care. I also have a passion for treating the underserved. And also, I really liked St. Hope because it offered all patients access to care.
So today we want to dispel some myths about breast cancer and give our listeners a lot more awareness and education. So we're going to be asking you lovely ladies a couple of questions, maybe get some insights, some facts, and see where the population can get diagnosed or screened for breast cancer.
Great.
So let's get started.
Okay, so according to breastcancer.org, about 1 in 8 U.S. women, which is about 13%, will develop invasive breast cancer over the course of their lifetime, according to breastcancer.org. So how do you think that we can reduce the burden that this puts on women?
So definitely, I encourage all women to first be self-aware of your body. And perform breast self-examinations at home, as well as follow recommendations as far as screening, the screening guidelines, right? So I know a lot of times that can be confusing for women because different organizations have different recommendations. So the most important thing is going to be to assess your individual risk with your primary care provider. So knowing what your risks are. So ACOG, the American College of Obstetricians and Gynecologists, they currently stand by the recommendation for women to screen at the age of 40. However, other bodies such as the USPS Task Force, they recommend women to screen starting at the age of 50. So it can be confusing. So people who are at average risk, they should screen starting at the age of 50, and they should continue that screening every 2 years until they achieve the age of 74. Women who are at higher risk, I would recommend them to screen more frequently.
So you did speak about doing self-examinations. Do you mind going into that and kind of explaining to our listeners how we can do that at home?
So the breast examination, the most important two things you're going to do is visually inspect your breast as well as palpate your breast. So you're using your eyes and your fingers to determine if you have changes in your breast tissue.
Okay.
The first thing you want to do is inspect. So you're going to stand in front of a mirror with no shirt on, no bra on, right? And you're going to look at your breasts to see, for one, are they symmetrical? Do they have dimpling in the skin? Do you have nipple inversion? Is there discharge coming from the nipples? Is there flakiness around the nipples? So you're really looking to see visually, do you notice any changes? The next thing you're going to do is stand in front of the mirror, and you're going to press your arms into your hips.
Okay.
So you're going to look for those same things, but in a different position. Once you've assessed your breasts with your hands pressed into your hips, you're going to raise your hands above your head with your palms together, and again, look for those changes. So that completes the inspection. The next thing you're going to do is palpate. So you're going to use the 3 fingers because it's typically the most sensitive. You're going to use the pads of the fingers and not the fingertips. And you can do it in different ways. So some women choose to start at the collarbone and work their way into the nipple area using a circular motion. Other women may choose to look at their breast as if it's a pie, and you take slices of the pie and pretty much, again, work your way from the collarbone into the nipple area using section by section. Okay. So when you do that, you want to be sure that you're using different depths of firmness because you're trying to assess different layers of the breast. So you want to start out using a soft amount of pressure, a medium amount of pressure, and then a firm amount of pressure.
And then if you feel any kind of lumps or anything of that nature, that's when it gives you like some sort of signal like, hey, let me go and check with my primary care provider and go.
Right. So you definitely do want to discuss it with your primary care provider. Not every lump means that it is a cancerous reason for the lump. Most of them are benign, but it's definitely worth having a conversation with the healthcare provider. The most important time to perform the breast self-examination, especially for women who still have menstrual cycles, is going to be 1 week after your menstrual period, because when you're on your cycle, your breasts tend to be more enlarged or swollen from hormones, right? So you want to do it right after your menstrual period. As far as positioning for completing those breast self-examinations, you can lie down, because that position kind of thins out the breast tissue. It makes it easier for you to notice any changes. Or you can do it in the shower when it's kind of slippery and your hands can move a little bit more smoother across the breast tissue.
Okay. So like when, let's say I want to go, let's say I'm a lady. Obviously I'm not. But let's say I do everything and I'm like, you know what, I see something, I feel something slightly abnormal. Let me go and talk to my healthcare provider. What are the types of screenings? Because I know we have screenings. What can we kind of dive into that? Like, what is the process like?
So if it's just a routine screening, you haven't found anything, you're 50 years old, and you're just going for your yearly mammogram. Like I make mine in October. So every October I go. That's just a routine screening, and there's no copay usually applied to that or no cost sharing. So that's pretty easy for most women to get. And other places for uninsured women will offer the discounted cost. If it's a diagnostic, if I report to my physician that, I did feel a lump or the nipple's inverted and leaky, that's going to be a diagnostic. So it's a much deeper evaluation. They're definitely going to use some 3D. They may also do an ultrasound. And the doctor, the radiologist or technician is going to really look deep at that tissue to see where that abnormality is and then consider further treatment if needed.
So Sean brought up a good point that I wanted to mention. He said, if I was a woman and I'm not, that's a common myth with breast cancer, that only women get that. Can we talk a little bit more about that?
Yeah, so typically male breast cancer currently accounts for 1% of breast cancer diagnosis. So typically right now, as far as guidelines, there are no recommendations as far as men completing a routine screening. But definitely we do encourage men to also be familiar with their breasts so they can notice any changes and speak to their healthcare provider if a mammogram is needed. Transgender females who were born men at birth, they're also at an increased risk for having breast cancer due to them taking hormones. So we know that the hormones increase a person's risk for breast cancer, and so they have a higher percentage of having breast cancer compared to a male who is not taking hormonal therapy.
Good to
And that's
know.
great. And I'm glad Dr. Prince brought that up. It is inversely related in men or females who are taking testosterone. That risk goes down. So we definitely think it has something to do with the hormones that they're taking. Men should also know the other risk factors. If they've been told that their family member is BRCA1 or BRCA2, meaning they have the gene for breast cancer, that male probably does need to go ahead and have some type of sequential mammogram or testing, at least speak with their doctor about it. Smoking and some of the other risk factors that we see for cancer in common may increase the risk also.
Okay. Now I wanted to piggyback real quick because we do have a transgender population that does come to St. Hope. Would transgender people also do the exact same examinations as women would do when it comes to trying to examine, like start from the collarbone, work the way around to the nipple area? Okay.
So that is just standard for anybody who performs breast self-examination, regardless of your gender.
Okay. And then they would also be recommended to do like a mammogram screening at the time that they come in for their appointments if they have any kind of issues that the provider may deem.
If the provider feels that there are abnormalities that warrant a mammogram, or if that patient is at risk, like Lynn stated, if they have the BRCA gene, then of course we would send the patient for mammography as well.
So it's a few steps first. The
And it doesn't matter if-
then mammograms, and then...
And it doesn't matter if they have implants. So sometimes people think if you have implants, that means you either don't or you do need to. That doesn't make anything. And in our transgender population who may have received implants, they still could be at risk, especially with taking hormones.
Okay, another myth.
Another myth dispelled right there.
Okay. Y'all heard it here first. Okay, so this is all great information. I know St. Hope, we do offer a lot of services, and we are here to, as you ladies mentioned, serve the underserved. So are we currently offering mammogram services?
So the mammography is something new to St. Hope, which we're very proud to be offering to our patients. It will be offered at the Northwest location, tentative November towards the fall of this year. We do offer it at a reduced price compared to other imaging departments in the Texas area. I'm not sure if you guys are aware, but the standard cost for a mammogram can range anywhere from $100 to $250. So
not today.
we will be offering that to our patients at a competitive rate. And as a provider, I'm very excited about it because a lot of our patients who are underserved or who do not have insurance, they don't get the mammogram because it is expensive. So that's one other initiative that we're taking so that we can improve our quality of care in our patient population.
And we can even piggyback with the great thing about it happening at St. Hope is because I know I've mentioned it a couple of times, we have a transportation service. So a lot of times when patients leave the clinic, and I know me working at the front desk, when we're giving the orders out, people are like, well, where can we go? And it's like, I don't have a car or I have to Uber. So it's a good thing that we offer a transportation service, and now we can actually bring patients to our Northwest location and to future locations if they offer mammography services from our transportation, so they don't have to worry about the stress of I need to find money for a ride or et cetera, et cetera.
I think it is challenging, especially because, when you're going to someone else, if you've been coming to us, you've developed that relationship of trust with St. Hope. And then when we have to send you out to somewhere, that same relationship doesn't always transfer. So if you tell me I have to go across to blah, then I don't know if when I get there, blah's just going to charge me this amount of money, or are they also going to need something else? And that's where our patients get very insecure about a quoted cost even from an outside party.
Very true.
That's true. So I did want to kind of talk about any other ways to kind of lower my chances of getting breast cancer. I know you said do the regular screenings, self-screenings on myself, but anything related to like health, exercise that maybe I could practice to lower those chances? So
research shows that most breast cancers, or let me say one out of 3 breast cancers are actually related to modifiable risk factors, right? So modifiable risk factors, those are things that you have control of. Those are things that you can change. And so the most common 3 modifiable risk factors that can lead to breast cancer would be obesity for one. So anybody with a BMI over 30, and that's usually calculated based on your weight for your height. The other one is physical inactivity. So currently, physical activity guidelines recommend that adults engage in at least 150 minutes of moderate intensity physical activity a week.
Okay.
So that's 30 minutes, 5 days a week.
Moderate. I was like, okay,
moderate
I was trying to carry the 1 and the 5. I was like, okay, I'm gonna be, okay.
So that's 30 minutes, 5 days a week, right?
Okay.
And the activity, what's considered moderate intensity is like brisk walking, okay? In addition to that, you should 2 days a week be engaging in muscle strengthening activity. So most people don't meet the physical activity guidelines, right? So that's another modifiable risk factor. The other one for women would be alcohol consumption.
Okay.
So currently the recommendation is women have 1 or less than 1 alcoholic beverage per day. So those are 3 modifiable risk factors that can reduce your chances of having breast cancer. Other things can be like having a child before the age of 30, not being on birth control for extended amounts of time, because we know that the hormonal exposure can increase your risk for breast cancer. Women who have gone through menopause and who are taking hormone replacement therapy and they're on estrogen and progesterone, that increases their risk for breast cancer. So those are things that you can change. Non-modifiable risk factors are things that you cannot change. So that would be getting older, right? So research shows that approximately every 10 years, your risk for breast cancer goes up just due to age. Another thing is having, as Lynn discussed earlier, the BRCA gene. You cannot change that. Those are things that those are passed down to you from your parents, right?
Now, Dr. Roberts, real quick, I didn't mean to cut you off. Can you go into the BRCA gene just a little bit for me?
Yes.
Just because I want to be educated for myself because I've never heard of that.
So more than likely, if you have the BRCA gene, a mother or a grandmother has told you someone who has had cancer in the family. You can do the genetic screening, but that's not really something that's common. But for females who do have that history, you can do it. Once it's determined that you have that BRCA gene, your risk factor is about 80% greater. So you are seeing young women who are making the choice to do elective mastectomies because they don't want to worry every year of, oh, is this the year I get cancer? Is this the year? Those women often start screening in their 30s or even their late 20s. And also they're sitting there and they feel a sense of that they're just waiting to get the mammogram that says they have cancer, and then they have to deal with that. So they will go ahead and make that choice. Others choose to just wait and get frequent screenings, and then if it occurs. But if you have that gene, hopefully someone has told you, and then you are getting more frequent screenings. If you don't, you can now even buy at-home kits like 23andMe, a frequent genetic screening. Offers a kit for it. But it's not recommended that we all go out and get the BRCA gene screening for 1 or 2. Okay, that's not recommended.
So usually if it's a first-degree relative, so your mom, your sister, a daughter, or if you have multiple family members who have had breast cancer.
And that's where that question comes in, because I know a lot of providers will ask, does your family have a history of breast cancer?
And know the cancer registry, there is a huge database that keeps count of all this. So they're very good at the cancer registry, and our local cancer center would be very good at letting you know that, telling you how to educate and tell your family members, and then even helping in the follow-up with them.
Okay, so I know you're speaking on risks to lower your chances of getting breast cancer and things of that nature. So I kind of want to, from a patient's view, Lynn, I know you mentioned that you do get the screenings done regularly. Are there any like do's and don'ts before screening that we should be aware of?
So, yes, usually when you register to get your mammogram, they'll give you a little sheet, and they'll tell you some common things like don't use lotions, don't use oils the day before or as you go, don't do deodorant, because sometimes it will reflect and dilute the screening itself. So that's not advised. The other thing in going, I mean, like I said, I've done this at least 20 times. So people often get scared. There is a sense of that squeezing. It doesn't really hurt, but there is a sense of those 2 plates coming down. And they're just little plastic plates, and they come down, and they take multiple images, kind of like a deck of cards. Think of it like a deck of cards. It's taking several little images, very thin slice, that it's going to put back together to see that area. And so there'll be a kind of a squeezing. I think the environmental and the psychological impacts of the screen itself are what sometimes deter women from coming back. So when you go in, depending on where it is, and now they've tried to make them very spa-like. So a lot of times you'll get a nice terry cloth little robe, and you're told to undress from the bottom. You have lockers that you stick your purse in. And they've done that on purpose because people feel very vulnerable, or females do, when they go and they were just given a hospital gown, told, oh, go ahead and take off your bra and your shirt. Don't have underwear on, do you? You didn't put any lotion on last night, did you? And then they go and expose themselves, and they sit and wait and go into what's a cold room. And someone sits there and kind of squishes their breast. And if you have dense breast tissue, which is an increased risk in itself, there may be a little more of a squeezing sensation. It also, I've noticed over the years, it's very tech relevant as to how uncomfortable it is. Some techs that I've had do it, I'm like, okay, if this squishes much more, I'm going to tell this person. And others, it's been, are we through? So I think it's very tech relevant. Now, though, you do see them, I've gone now where they've got fancy $high coffee machines. They're like a spa.
They're making it nice.
But the spas don't always fit. The robe doesn't always fit. And that's very uncomfortable because you're sitting there with all these women in a robe waiting to be called back, and you're having to keep pulling your robe.
So how long does the exam typically take?
The exam itself is usually only 5 to 10 minutes. That's what I'm saying. It's really the psychological stuff about getting there and then rushing around while you're there. Nobody really wants to tell anybody, oh, I'm going to get my mammogram.
Right. The myths behind it.
Right.
Luckily at St. Hope, just a quick plug, You're not in a waiting room with a lot of women. It's just one room for yourself. It's a spa experience, as Lynn was mentioning. Okay, well, that's kind of good information to know.
Yeah, especially for somebody who I haven't had a mammogram before, and I've just heard my parents and my aunts, and they're just like, they smash. I'm like, what? Like, wait a minute.
What's going on in here?
And I think the most important thing is that you go to the place you went to before. When I moved from another state to here, I didn't have that. So the first time I had to do a diagnostic again. And I remember the local place telling me, oh, it's going to be, $900 and something. And I'm thinking, I got insurance. But it was because I didn't have previous films really for them to compare it to. I happen to know that I have a little calcified spot. And also, it's not a tumor, it's not a cancer. But you want to see if it's changed from last year's film. So for us, since we're starting as a new institution, what we're going to recommend for our patients is that they bring their previous films with them, or that they get the written previous summaries.
That actually kind of ties into something that we also wanted to ask you guys. When you're bringing in your previous films and whatnot, how do you plan or schedule your mammogram? Like, is there like a booklet you should bring with you, like with the chart, imaging records? Do you plan to do it like once a year?
Kind of like the selfograms that Dr. Prince was talking about. You should decide a day of the month, and it's going to be then, except when it's near your period. So like for me, it's always kind of been the first of the month. Mm-hmm. Some people decide the 30th, the 31st, or 15th, whatever day you want to be. And then for me, I always go for my mammogram in October. That's my month. And also, I go every year in October. And most women, I see when I ask patients, they'll say, oh, no, I go in February to get mine. Or I go in this. And that's the way really to handle it. Have a routine time that you go.
Yeah, and some women go around their birthday. So they know that, hey,
exactly.
I'm turning another year old. So let me go ahead and do, my preventative screening. So it just really depends on what works for you and what will help you remember. To have the screening done. And I did want to add, I know we talked about breast self-examinations earlier. Mm-hmm. So the breast self-examination is not to replace mammography. So it's supposed to be used in addition to getting your routine mammography screening. So it's not to replace it, but in addition to.
That's a good point.
And
some people will be like, I
could do it at myself.
Yeah. I don't need to go in there.
Please do not do it yourself.
Please.
Please do not do it yourself.
But while we're touching on that, so this is speaking to another myth. So a lot of women feel like, oh, I do my breast self-examination at home. If there's a problem, I'll know, so I won't go get the mammogram. They'll say, oh, if I have a lump in my breast, that means, then I need to get my mammogram. Mm-hmm. But typically, there are a lot of patients who are positive for breast cancer who have a lump, but it does not always mean that a lump will be present in order for you to have breast cancer.
Now, with that, I just wanted to ask, as a woman, do you have any kind of like pains in your breast? Even if you have a lump, is it a possibility that there will be no pain? So, because a lot of people just indicate if I have pain in my breast,
painless, unless they treat. And think deep ductal cancer. So deep inside where that type of tissue is, that cancer has often been growing for maybe up to 5 years.
Oh,
and it's a while before we detect it. That's why the age can be 50. But yes, those types of cancers you may not see. They're deep down. They don't grow a big lump in that tissue most of the time.
So I'm glad that Dr. Roberts touched on this. So most cancers actually, there's different anatomy for the breast. So you have ducts, you have lobes that produce milk, you have connective tissue, you have fat. So most of the cancer typically will start in the ducts. And by the time it turns into a lump, it has probably already moved into the lobes. And so that's why we say you should be performing, your breast self-examinations, knowing what's normal for your body so that you will recognize a change early on.
And the tissue, or women who have what's called high density, and if you're a female and you've had your mammogram, you probably have been told that. The reason they're telling you that is because there's an increased risk. So just think, that tissue is going to be very tight and be very dense and could hide something.
Okay.
Where those who do not have, and it's not just large-breasted women who have the high density, but that is kind of a greater time that we see that characteristic is in large-breasted women. So that's why you want to keep going back and not just go one time and think, oh, I didn't have anything 5 years ago, so I don't have anything now. Mm-hmm. There may have been something missed or that was small at that time that in the following year when they scan it, they're going to say,
something doesn't look right here. So I did want to touch on another myth. I know, Lynn, when you said you go get your exams, a don't is like not to wear lotion or deodorant. We're not saying don't wear deodorant, just for the exam. So I know...
don't wear it on that day. They really don't want you even wearing it that evening because of the aluminum is absorbed in, and most deodorants have aluminum in them, and that can interfere with the actual scan itself.
But does the deodorant cause cancer? I know
No.
that's another myth.
No. So the thought behind that is that deodorant that has aluminum or other chemicals, they get into the lymph nodes, they travel down to the breast tissue, and now you have these toxins in the breast tissue that can contribute to breast cancer. But that is a myth. So there's no research that supports the idea that deodorant can cause breast cancer.
So wear your deodorant.
What about, I mean, I know this sounds like so crazy, but I remember somebody telling me like wearing a bra, or underwire bra, and the metal being on your skin. I'm like, this so soft, right?
Yeah, it's supposed to just be out here.
So that idea stems from people thinking that the underwire can actually restrict the lymphatic fluid from flowing out of your breast.
Okay.
So it causes accumulation of toxic substances. It sits there and contributes to breast cancer. So that's actually a myth as well.
Right, and y'all probably aren't old enough, but we used to have bras that didn't have underwire. So even then you would hear that, and a kind of an old wives' tale was not to sleep in your bra.
Okay, I've heard that.
Was a way to avoid getting breast. All that doesn't
funny.
count.
Wear it all day, just not at night. And you'll be okay. Like, what? Okay.
Yeah.
That's good to know.
I did want to highlight the fact that African American women are affected by breast cancer or diagnosed with breast cancer at an earlier age compared to other ethnicities. So typically what you find is African American women, they do get diagnosed with breast cancer before the age of 50. They're more likely to die from it, and they're more likely to have triple negative breast cancer, which is a breast cancer that is more aggressive, it's harder to treat, it spreads faster, and the treatment options are fewer compared to other types of breast cancer.
So when they come in just for like a physical, are you still doing breast examinations?
Yes,
on
ma'am.
Okay.
So we still do breast examinations, and nationally, numbers show that 80% of African American women, they screen more, followed by Caucasian women, then followed by Hispanic patients, and then other nationalities. So they are completing their screenings because they are at an increased risk.
All right, and I think as we get to those types, you can look at treatment on some of the things that have kind of changed in the literature. Harvard is one of the universities that has done a lot of research in this, is that just because you had breast cancer 3 years, 5 years ago, 10 years ago, does not exclude you always from estrogen. You just need to have a good relationship with your doctor and make those determinations. You may also be able to use topical estrogens, because just because I've had breast cancer doesn't mean I wouldn't want to get an important part of my health, my hormone replacement therapy. And even as early as, say, 10 years ago, a woman who had breast cancer, doctor said, no more estrogens for you. You can't have your hormones. So there have been some changes in literature and in research that women need to be aware of and need to speak to their provider about and consider all their options.
So I have a question. Let's say a woman was diagnosed with breast cancer and, some years pass by. Do they need to still do it like once a year? Should they do it more? Or do they still follow this standard once a year for mammograms and
follow
diagnostics?
the recommendation
Just
of their
follow it?
oncologist. They'll be under an oncologist care usually for up to 5 years, and they may be on some estrogen blocking drugs. So during that time, they won't take hormones, and they'll follow closely with them and anything they see. Then usually after, say, the 5-year mark, and it can be different per doctor, the oncologist will decide that maybe we can decrease or stop this drug, and maybe the screenings can return to X time. So it's really one of those things. But the really neat thing is that in today's world, once we know you have HER2 or a certain type of cancer, ductal cancer, there's a behavior. We know exactly what that cancer does. We know how to target the treatment of that cancer and what's expected going forward. So it's a real clear pathway. It's about meeting those screenings and staying in close relationship with your healthcare team.
Well, that's very reassuring.
Yeah.
Because I know that diagnosis can kind of like scare you and you don't know what to expect. You're just like, oh, breast cancer. I know the cancer word just scares people in general. So that's very reassuring to hear that there's treatments and plans and,
After follow-up care for at least 5 months.
So let's just say if I wasn't a patient of St. Hope and I was just coming in to do a mammogram screening, would I be able to do that at St. Hope?
So yes, mammograms are kind of different. They're a service that's offered to 3 different groups. So even if you don't have an order, you're not a patient of ours, and say you're 51 years old and you've never gotten one of those mammograms, you want to go, you can actually walk in and say, I want to get my mammogram. And we will facilitate that for you, and that's by law that has to be available to you. So you don't have to have had the money to go pay for a primary care and invest a couple of $100 there to get the order to come get your mammogram. You can just walk in and request it. You can also have maybe whoever your primary care doctor is give you a referral and bring that referral to us and get it. And that will probably be more cost effective for you than maybe where you were planning or whoever he's affiliated with or she. And then, of course, if you're a patient of ours, our providers will write the order and facilitate the process for you.
For a lot of our patients with chronic illness like diabetes, HIV, does that have any tie into breast cancer, or does that increase their chances or risk of getting breast cancer?
Anytime you have other, and I don't have the exact data on this, but we know anytime a patient has other than optimal sense of wellness. So anytime you have one illness or 2 illnesses, and maybe you're not really good at watching that blood sugar, maybe a lot of times your blood sugar is 150 and above, then you are setting yourself up for risk for other illnesses. And so one disease too often piggybacks off of another. Your immune system and inflammatory markers, and as we look at cancer today, what we're looking at is the inflammatory markers and the immune system. And we definitely know that in diabetes, the immune system is decreased and there's more inflammation in the tissue. Overall, inflammation is what is most damaging to the tissue. So higher inflammatory markers, once again, another illness we can think of that does that is what?
HIV.
Our HIV patients.
Okay.
They're the real damage is the inflammatory markers.
And just to speak to that, so with our HIV population, a lot of times the patients are undetectable. But the HIV virus itself constantly provokes the immune system, right? So you have that chronic inflammation over time, which puts you at risk for certain health conditions, cancer in general to be one of them.
Okay.
And that's why we always seen that group of AIDS-related cancers was really about the inflammation and devastation.
So I just want to say thank you for providing us with well-needed information. I hope our listeners gained a few gems from this conversation.
Breaking some myths over here.
Yes,
So wear your deodorant and your
Wear your bras.
Yep.
Please.
Exactly.
Hashtag Mythbusters.
Especially in Houston, wear your deodorant. Okay.
Amen.
But yes, do your self-examinations. I'm glad, I know the different positions now because I was
Okay,
not.
I want to go home.
Yeah,
Start at the waist.
because I didn't know. I know you see the diagrams and they just like lift your arm, do this. I did that, but I didn't know it was supposed to just be
Switch it up on the angles. That's a good plan.
But yes, so I thank you for all that well-needed information. But if you guys have anything else that you would like to just let our listeners know, this is definitely your platform to do it. So the floor is yours, and I am all ears.
I think what I often tell my patients is I encourage them to do the breast exam like Dr. Prince spoke to and all, but I don't want them to feel burdened that they're going to diagnose cancer. That's not why I'm asking them to do that. I'm expecting that maybe they'll do it over and over and it'll come rather rheumatic for a year, 2 years, 5 years. But one of these days they'll do it and something will feel different. And they may not run out and panic to the doctor then, but the next month, that spot feels kind of bigger. It feels kind of different. That's when I want you to come see your provider. That's when you really need to be. So I don't want my patients to feel like, oh, you think I'm going to diagnose cancer. You're not. It's just one tool in the toolbox to help prevent breast cancer.
And I would just like to say thank you all for having us. It has been a pleasure to be able to provide information to the community in hopes to reduce the breast cancer burden, as well as get more of our patient population and patients in the general population to come and have their screenings done. So thank you very much.
Amen. Thank you.
So yeah, just make sure if you are interested in getting mammography services done, you can go to offeringhope.org and you can set up a new patient appointment, or if you're an existing patient, you can always call one of our clinics and one of the front desk staff would be more than happy to assist you.
You can always use the chat feature on the website also.
And yeah, so I just want to thank you ladies also for your time. Rachel, do you have anything?
Yes. Thank you, ladies. I feel like Ajai said, we learned a lot today. And I hope you all tune in for our next podcast. We're going to be discussing some vision information with you all. Another wonderful service that we offer here at St. Hope.
So thank you all for your time. And for our patients and listeners out there, thank you as well. And just remember, here at St. Hope, you are more than just a number.
Thank you.